What are the differences between the systolic and diastolic heart failures? There are two types of heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. Systolic heart failure is a heart failure with reduced ejection fraction, whereas diastolic heart failure is a heart failure with preserved ejection fraction. Why there is reduced ejection fraction in systolic heart failure? In systolic heart failure, the walls are thin and powerless and unable to push blood into the systemic circulation, and there is cardiac dilatation. Whereas in diastolic heart failure, which is where there is preserved ejection fraction, the walls are thick, inelastic, and there is impaired relaxation that leads to impaired filling. In systolic heart failure, there are weak systolic contraction that leads to decreased in stroke volume, decreased cardiac output, and increase in ventricular diastolic volume. Whereas in diastolic heart failure, because of the inelasticity and impaired relaxation, cardiac chambers don't fill, so there is decreased stroke volume and decreased cardiac output, leading to heart failure. In systolic heart failure, there is cardiac dilatation, increase in arteriovenous oxygen differences, and decreased exercise tolerance. What are the causes of systolic heart failure? Dilated cardiomyopathy causes systolic heart failure. Myocardial infarction and alcohol cause systolic heart failure. Pregnancy, doxorubicin, and mitral regurgitation also cause systolic heart failure. Whereas hypertrophic cardiomyopathy, hypertension, coarctation of aorta, patent ductus arteriosus, myocardial ischemia, and constrictive pericarditis cause diastolic heart failure. Why there is systolic heart failure in myocardial infarction? If a big area of the ventricle is involved in infarction, that leads to necrosis and thinning of the wall, leading to systolic heart failure. Why there is failure of relaxation in ischemia? Ischemia causes decrease in ATP required to decrease calcium for relaxation in sarcoplasmic reticulum. Decreased delivery of calcium to contractile tissue leads to abnormal wall motion. Common to both diastolic and systolic heart failure are ischemia, myocardial infarction, and hypertension. These disorders may cause both systolic or diastolic heart failure. What are the differences in the clinical features of systolic and diastolic heart failure? Systolic heart failure is usually acute, whereas diastolic heart failure is usually chronic. Systolic is a forward failure and diastolic is a backward failure. Systolic is a low cardiac output heart failure, but the cardiac output may be normal at rest but fails to increase in exercise or exertion. Inadequate discharge of blood in the arterial system leads to decreased renal perfusion, increased sodium reabsorption from proximal tubule due to activation of the renin-angiotensin system. In systolic heart failure, there is vasoconstriction. In diastolic heart failure, there is venous pooling. Whereas in systolic heart failure, third heart sound is present. Why there is pulmonary edema in the left ventricular acute myocardial infarction if it's massive? Because in the left ventricular AMI, there is back pressure on the pulmonary circuit that causes pulmonary edema, dyspnea, and orthopnea. Whereas in the right ventricular failure, there is venous congestion that leads to hepatomegaly, peripheral edema, and raised central venous pressure. So what's the difference in the treatment of systolic and diastolic heart failure? Treatment of systolic heart failure depends upon the percentage of ejection fraction. Cornerstone of the treatment in systolic heart failure is ACE inhibitors and beta blockers. If the ejection fraction is more than 40, then ACE inhibitors are used. But if the patient is intolerant to ACE inhibitors, angiotensin receptor blockers can replace ACE inhibitors. If the ejection factor is less than 40%, then beta blockers are added to ACE inhibitors. Contraindications to beta blockers are bronchospasm, bradycardia, and heart block. If ejection fraction is less than 35%, aldosterone antagonist spironolactone, eplerenone, triamterene, and amiloride are added. Diuretics are used in systolic heart failure if there is fluid retention. Two diuretics used in systolic heart failure are furosemide and metolazone. What's the advantage of furosemide over the thiazides? Furosemide that act on the thick ascending limb of the loop are more potent than thiazides, and they work even if the GFR is less than 25 milliliter per minute. That is, they can be given in chronic renal failure. And number 3, they reduce the pulmonary capillary wedge pressure before the diuresis. So they act very quickly on the pulmonary circuit. And when do you use digoxin in systolic heart failure? When there is atrial fibrillation. Digoxin is positive inotropic and negative chronotropic. It increases the stroke volume, increases cardiac output, increases ejection fraction, and causes diuresis. It decreases the heart size, decreases heart rate, decreases oxygen demand. The drugs used in diastolic heart failure are calcium channel blockers and beta blockers. Examples of calcium channel blockers are verapamil and diltiazem. Calcium channel blockers are contraindicated in systolic heart failure because they reduce inotropy and stroke volume, but they improve the ventricular relaxation and reduce heart rate, which permits more time for filling. They promote regression of cardiac hypertrophy, reduce arterial pressure, and improve coronary flow. What are the advantages of calcium channel blockers over the beta blockers? Beta blockers can't be used in asthma, COPD, sick sinus syndrome, conduction defects, Prince-Metal angina, and peripheral vascular disorders. Beta blocker advantages are they promote regression of hypertrophy, reduce the blood pressure, reduce heart rate, and they reduce inotropy. So what are the drugs that are contraindicated in diastolic heart failure? Inotropes and digitalis are contraindicated in diastolic heart failure.